Let me just say at the outset, it's been a great day for me. I left Princeton, New Jersey early this morning and flew here, and then upon arrival, I have really spent the last 4 to 5 hours primarily with students as we've talked about a range of issues centering on health, on healing, on public service, on being a physician or a healthcare provider one-on-one, and then losing my mind and running for the United States Senate, and having a wonderful 12 years in the United States Senate representing all of you and your families, and even if you're not from Tennessee, as Majority Leader of the United States Senate representing you, really trying to do the same thing that we do in medicine and in health and in public health and in occupational health, and that is to heal, and to heal one-on-one as a physician, and then go to the United States Senate and heal one on many, 7 million, 6.5 million Tennesseans, and ultimately as leader, several hundred million people, as we did the best to address issues important to you, to your well-being, and ultimately to your health. And now I am teaching full-time, and I'm doing that for many reasons, but primarily to contribute in some small way to the issues that we'll talk about tonight, and that is the issues of not so much health one-on-one and not so much one on a community, but indeed one or many on many. And indeed we'll talk about the issues of global health around the world. It's an honor for me to be here with this 25th celebration of the Lamb Lecture, the legacy that he both established in terms of vision, in terms of the contributions to the profession, to education across this state, across the region, and indeed across the world. I titled my talk tonight, Hope Through Healing, with this whole backdrop of using medicine and global health as a currency for peace. I put down a physician senator's unfinished journey because I've had that privilege of doing heart and lung transplants and heart transplants and doing heart surgery and then serving as a United States senator, but we really just touched the tip of that iceberg of the challenges that are out there. We're going to talk a lot over the next 40 minutes or so about issues that are a long way away from East Tennessee, and I have there Africa sort of highlighted, but in truth not that far away, because the same issues that we're addressing overseas we're addressing in the United States, in America. I'm going to also open because how does it all fit together? It's a sort of the question that I have to answer all the time. How, being a doctor and being a senator, why? How does it fit together? And your interest in global health, it really comes back to what Martin Luther King said in his letter from a Birmingham jail, where he says that we are caught in this inescapable network of mutuality. We're tied in this single garment of destiny, and what affects one directly affects all indirectly. It's a small world we live in, and we're going to take a little journey here, and I'll show you how small it is. Africa itself, and I'm using Africa really as a surrogate for the developing world, for poor countries, for sort of middle-income countries. But this is my impression of Africa, and it's quite different than what many of you might think of Africa. It's the joy, it's the happiness, it's young people, it's looking ahead optimistically, the beautiful sky, the beautiful land itself. This is one of the medical mission airplanes that I use and that I fly as I go back in the bush throughout various parts of Africa. So my view of Africa is very optimistic. Although if we look at the realities today, it is tough, it is difficult, it is challenging from a health perspective. I want to do 4 things tonight, and I'll be moving pretty quickly, but I want to talk a little bit about children and a Survive to 5 campaign, a global campaign that I'm now chairing, that is a fascinating campaign in that it's an easy one, yet one that has a huge mission and a huge challenge before it. I want to move to HIV, AIDS, malaria, the big 3, the ones that killed 3 million, 2 million, 1 million respectively in the slide every year, every day. And then with that backdrop, comment on using medicine as a currency for peace. And then answering the question of what we can do, what you can do, and what I can do as we address these big challenges. So topic number one, survive to 5, children's health around the world. I start with this picture because it really does come down to this bond in many ways of a mother and a child. And everything centers, if we're going to look at the child at age 1 or 1 month or 2 or 3 or 4 or 5, we also have to look at the health of the mother. By this time tomorrow, 28,000 people by tomorrow night, children between 0 and 5 years of age will die. 28,000. I mean, it's a tragedy almost incomprehensible. That's how many are going to die over the next 24 hours. And if you go 20 years ago, that's how many died. It's about 10 million a year. We've made zero progress really over the last 15 years in terms of the absolute numbers. But if you and I act, and this is the good news, and this is why I'm dedicating the next block of time in my life, whether it's 5 years or 10 years or 15 years, to the simple fact that if we act, using tools that we'll talk about, we can save about 2/3 of those people. Why? Because they are dying of very, very easy things to cure and easy things to treat. The tragedy, you can start with the mother here, basically about 500,000 maternal deaths. The health of the mother in many ways determines the health of the child. After the child is born, about 4 million newborns die in that first month of life, and then 7 million deaths of children occur between that first month and 5 years. And you have to dissect it out exactly into those 3 categories if you're going to target very specifically, be held accountable, and accomplish our goals. What do they die from? Well, they die from diarrhea, usually comes from unclean water or sanitation mixing with water. They die from pneumonia, and that's probably a better term than acute respiratory type disease, but pneumonia because people understand it, and measles and malaria. But the good news is that all of those can be prevented or treated, or both. Those children do not have to die. The tools exist, and the tools that we have today are cheap. They're inexpensive. They've been demonstrated in the past, and that is what's key. It's a matter of looking at sort of a population of 6 billion people in the world and looking at that bottom billion and making sure the distribution of these tools which work, we know they work, are distributed appropriately. There are 3 goals, and I'm not going to go into the goals themselves, but we've made some progress in the 1 to 5 years of age. I was in Bangladesh about 2 months ago, and again, the story is pretty good. Over the last 20 or 30 years, we've made progress in 1 to 5, but in that first year of life and in the newborns, we really have not made the progress. And therefore, in my Survive to 5 campaign, I'm going to put a lot of emphasis on this saving newborn lives. The health of mothers. If you don't have a healthy mother, as I mentioned, you're probably not going to have a healthy baby. And again, the 1 billion people. It's interesting, if you look at the 6 billion people in the world today, the 5 billion over the last 30 years, the top 5 billion are doing pretty well in terms of growth, whether it's growth in GDP or per capita spending, pretty good. The bottom billion are stagnant or moving in a different direction. So I think we do have to look at extreme poverty as we're addressing these issues of global health. I do a lot of traveling. I've been in and out of Sudan just about every year for the last 10 years, starting with about 1997 or 1998. A tough area. All of you know Chad. Right now, Chad is sort of in this box here. This is the Sudan. I spent a lot of time down south here. Khartoum is right there. This is the area of Darfur. It's probably about the size of West Virginia, and it's a fascinating area. I was just there a few months ago. This box right here is this part of the map. This is the country of Chad. There are all these refugee camps up and down here. West Darfur, this is where Save the Children spends a lot of time. This is as you're flying in, this is what you see in Chad. I mean, both in Chad, but also in Darfur itself. This is in Darfur flying in, and you see all of these little, what are they? Are they buildings or are they huts? I'll show you shortly what they are. But look up in here, there are thousands and thousands and thousands. Each of these are huts. These are the ones that are close up, and it goes on and on and on all the way around. Huge area. This is what it looks like on the ground. This is what you were looking at before. And right now, a lot of the conflict there was about 2003. Since 2003, things haven't gotten a lot better. No, there's no real active genocide going on. Still some killing today, but the public health challenges there remained significant. This is my wife, Karen, who's not with me tonight. She's giving a talk down in Georgia on a health-related issue. But this is one of the typical clinics there in Darfur as we treated some of the emerging diseases. And because things are so crowded there, you have this dissemination and this communicability of disease, which is a huge public health challenge we have today. So all of this, if you're looking at it, so we got 10 million kids dying every year now. We had 10 million dying 20 years ago. What do we start with? And you have to clearly start with goals. And the good news is that we have developed the so-called MDGs, the Millennium Development Goals. They are designed to achieve a more peaceful, prosperous, and just world during the 21st century. Well, right now, 189 countries have got together and made the pledge to reduce child deaths worldwide by 2/3. So if you have 30,000, it takes you down to 20,000, and by maternal deaths by 3/4 by 2015. We're probably not going to make those goals, but the goals are out there, and the strategy in terms of using these proven tools are there as well. I do a lot of talking in other countries. I'll be going to Egypt actually in about 3 days. Go to Europe a fair amount, and people say, where is the United States on our leadership? Why aren't we doing more? We're doing a lot. We're doing an unbelievable lot, both, HIV/AIDS and tuberculosis and malaria, but also in child health all around the world. This is just an example, and it's good for everybody to know in Africa of all the food now through the World Food Program that's going to Africa today, the developing world, that sort of bottom billion, 60% of it all of you are paying for. So if you go to Europe and people start being critical of the United States of America, let people know that we are stepping up. And this is the same thing that is true as in North Korea as well. We are the World Food Program. I put in here, and I was talking to some of the students today, and that's why I wanted to put this slide in. There's a lot we don't know. So I say these tools are all proven and they're inexpensive, and I'll come to that shortly. But right now, we don't know whether or not this plumpy nut is going to work or not. But instead of just giving food, those big bags that I showed you were basically corn, not a lot of nutrients, a little bit of fortification in there, but there is no animal products. There are no real minerals in there, and there's no milk in there. Plumpy nut is brand new, but it is being debated right now, sort of in the world food community, whether or not we should be using it. I can tell you from the doctor's standpoint, it is life-saving. You give plumpy nut, which is like peanut butter. It is a sweet peanut butter. I eat it. It's very, very good. It has a lot of calories in it. But in addition to that, like peanut butter, it has a lot of both the protein, but also a lot of milk and a lot of animal source, and not just the corn base. And with that, you accomplish all sorts of things that we don't fully understand to the newborn, other than just giving calories, other than just feeding. And so follow what happens with plumpy nut, because right now the scientists, the medical community, the doctors, the nurses taking care of patients say it is immediately life-saving. Much of the World Food and the Nutrition Program have not endorsed it yet. Well, I'm pretty optimistic because we've got the tools and we've got the knowledge. Experts agree that past successes in reducing child deaths demonstrate clearly that with the existing tools, we can save 2/3 of these people under the age of 5 who are dying. Why can we say that? Because if you look at immunizations, you can see the success that we've had. You can look at vitamin A, you can see the demonstrated, proven, easy success that we've had. And you look at oral rehydration, which is basically, you have a baby, unclean water. I was in Bangladesh. The monsoons come in, the sanitation mixes with water. The babies get exposed to that. They get an infection. They have dehydration from their diarrhea. They go in cardiogenic shock and they die. I was at one hospital and there were over 1,500 people admitted every day with extreme dehydration over in Dhaka in Bangladesh about 3 weeks ago. We know how to treat it. Basically, you take, it's just water, you have to have clean water, and you have salts and add the salt to it, but it is literally life-saving. It is cheap. Immunization reduced polio cases by 99%. You see the other statistics, but 30 million children are still not reached every year with immunization services. Measles and tetanus kill more than 1 million people today. Again, things we can immunize. And immunization coverage for diphtheria and whooping cough and tetanus has been stagnant through the 90s. Real progress in the 70s, progress in the early 80s, but completely flat. But these are the sorts of things that we can address, cheap, inexpensive, and proven. Vitamin A supplements, we know they saved 1 million lives, clearly documented between 1998 and 2000, yet only 50% of children under 5 in developing countries receive these inexpensive life-saving supplements. I mentioned I was in Bangladesh, so we've been talking about Africa here, but over in Bangladesh, a lot of people say it's Bangladesh in Africa, so I show this map, and it's kind of funny. On the other hand, as you know, we're not very good in geography, so I show the map. Bangladesh, this is the country itself, and this is Dhaka, the capital, and this is up in Sylhet, where I was participating in a Save the Children program. And again, for 3 days, you just give these 2 to 3 little drops of vitamin A, and maybe every 3 months or every 6 months, and it is life-saving for these children. Oral rehydration, we talked about an estimated 1 million people in terms of deaths prevented each year, but we have large disparities where the ORT is not getting out to the communities that actually need it. Antibiotics are cheap, about 15 cents. Life-saving if you get the antibiotics to children. Right now, this lack of access to clean water is probably the #1 killer of kids under the age of 5, but close to it is typical pneumonia, which again can be cured by these antibiotics. You can immunize a child for about $17 in the developing world today. Again, very inexpensive for saving that individual life. A malaria bed net, $5. Vitamin A, just a few cents. The second thing, HIV, malaria, and TB, I want to turn to. The HIV, I've mentioned here a personal journey for me, because when I was in medical school, nobody had died of HIV in the United States of America. It's pretty amazing. I mean, I'm old, but I'm not that old. And to sort of see what has happened over a very short period of time. On the floor of the United States Senate in 1996, I basically said that this is the greatest moral, humanitarian, and public health challenge of our time. At that time in our country, we were spending only about, maybe $150 million a year addressing what was clear, at least to this physician in the United States Senate, the magnitude of this problem. The real question that we have to continue to ask today is that what are we doing? 10 years from now or 20 years from now, when the history books are written, how are they going to look back at our generation, our academic institutions, our corporations, our governments today? Are we responding appropriately to this huge, huge problem? Well, the answer is yes. The United States of America, again, is leading the world in our contributions. And in those years of 1994 and 1996 and 1998 and the year 2000, we were not. We were not investing appropriately, but today we are. It began on January 29th, 2003. Nobody knew this. Nobody knew it, but the President of the United States, sort of halfway through his speech, read these words, or spoke these words. I propose the Emergency Plan for AIDS Relief, now that's called PEPFAR, a work of mercy beyond all current international efforts to help the people of Africa. Nobody predicted he would say this. A Republican taking on a virus that has historically been associated with gays or with IV drug abusers. But the President of the United States stood up where no other world leader was standing up to that degree, and no leader of this country had stood up to this degree in the past. He also said, I asked Congress to commit $15 billion over the next 5 years. Remember, I just told you we were spending less than $200 million, $150 million, and this president said we're going to spend on average, starting next year, $3 billion. A lot of the world didn't believe it. People said, you're not going to fund it, Mr. President. The President did fund it. In leading the world right now, the Global Fund, which is where a whole bunch of countries get together, about a third of that fund is paid for by your taxpayer dollars. PEPFAR, the program that I just mentioned that the President announced, $18.2 billion, not just $15 billion, but $18.2 billion has gone out the door to fight this single little virus. Our NIH, nobody knows this statistic, and I had to ask and dig for it, but $34 billion in NIH research. Your taxpayer dollars has gone to fight this one little bug, invisible, you can't taste it, you can't see it, this one little virus. And indeed, $197 billion, huge sums of money have been spent, if you add all of the expenses and all of the cost in fighting this one little virus by the United States of America. There is no country in the world, there's no continent in the world that can anywhere come close to the contributions that we have made in fighting this virus, which has so devastated the world and so devastated both the developing world as well as the developed world. The top line I have, one person dies of HIV every 11 seconds. That's today. We made real progress, but still one every 11 seconds, and one person acquires HIV every 6 seconds. Right now, 39 million people are living with HIV, and remember, there is no cure for HIV today. We've got good treatment, and people in this country get, for the most part, very good treatment, but we do not have a cure. New infections about 4.7 million, deaths each year about 2.9 million, and that will pretty much continue for the foreseeable future no matter what happens. Right now, this tells the story, I think, overall. The red, it's kind of hard to explain unless you're used to saying it, but the red is the loss of society by age group because of HIV/AIDS if you project to the year 2020. If you focus just right here, this is population in thousands, 0, 60,000, 120,000. This is age on the y-axis, so let's just take one of these, say 15 to 20 years of age. The green is how many people who will live. The red is how many people are wiped out because of this one virus. Who are these people? They tend to be between 24 and 35 years of age at the height of their productivity. They end up being teachers, they end up being doctors, they end up being nurses. Overall GDPs in countries in Africa continue to plummet. In places like Botswana, people used to live to about 59, 60 years of age. Now they live to 39 years of age. It is devastating to the economy and to humanity in these areas. How do I get involved? My involvement as a doctor, this is old Dr. Dick Furman up there, a good friend of ours that for the last 10 years I've traveled to Africa and indeed around the world as we do medical mission work. My own history, or early history of HIV, I said we didn't know much about it. It wasn't defined in the medical literature at all until 1981, and there were 5 cases in Los Angeles published in the MMWR, pneumocystis carinii pneumonia in Los Angeles. There was some suggestion in the editorial of being a cellular immune dysfunction, and we didn't know anything about it up until then. 1981 was not that long ago. In 1980, I saw a particular patient, treated 24-year-old recurrent abscesses. That patient was gay. I had no earthly idea. He died about 6 months later. In 1981 was the case reports. Throughout the mid-1980s, as we were doing heart surgery, we had to make decisions on if somebody is going to die and we have no treatment for at all, do we use public resources and operate on them if they're going to die anyway? We can operate their heart, but they're going to die anyway of something else, HIV/AIDS in the next year. Do we operate on them? Your surgical residents, if you're an attending, do you risk getting cut yourself because there's no treatment? And the answer for most doctors was yes. But do you have your surgical residents come in the room in the event they got stuck with a needle or a wire and died of that? Those were the ethical issues we had to address. In 1985, I was out at Stanford doing heart and lung transplants. The same thing, what we do, if you do a heart transplant, you take a heart out, you put another heart in, you have to give that patient immunosuppressants, cyclosporin, azathioprine, pneumonia. You suppress their immune system and they tend to get infections, and thus I began to study these emerging and resistant diseases that we began to see in the transplant population. And then in 1986 to 1994, we set up an AIDS clinic at Vanderbilt. It became the largest AIDS clinic, even larger than those in Memphis, for a period of about 4 to 5 years. So that's the physician component. That's why in some ways it's important to have citizen legislators. I was the only physician in the United States Senate at the time. The last one had been elected in 1928 before you elected me to go there. The second hat that I wear is as a policymaker, and we'll go through this fairly quickly, but in 1995, you sent me up to Washington. I went as a citizen legislator. In 1996, was on the HELP committee that rewrote the CARE Act, the Ryan White Act, and that particular bill focused on HIV/AIDS in this country. It is the bill that has given $20 billion over history, growing from $221 million in 1991 to over $2 billion in 2006 to fight HIV/AIDS in this country. And then in 1998, I began doing these annual medical mission trips on the ground, treating patients through Central and the Horn of Africa. And I saw firsthand the devastation, not just in America, but also overseas. I'm going to divert just for 1 second, because people say, well, Senator Frist, Dr. Frist, you're helping people around the world, but what about us right here in Tennessee? What about us in the Appalachian Mountains or in Memphis or in Nashville? Don't forget about us. And I think it's important for people to know that through Ryan White, we have addressed our challenges here in the country. And indeed, if you look for what is domestic HIV/AIDS spending, you can see from fiscal year 03 to 07, it continues to go up. And if you look at domestic HIV/AIDS spending, you can see it's about $18.9 billion in 2007. And if you compare that to what we're doing overseas, you can see that domestically we're spending $18.9 billion in 2007 compared to our 4.6 overseas. I think that balance is just about right. I was majority leader when that was determined. I think that's just about right. But the important thing for me to share with you is that we are focused right here in this country, and focused here generously and predominantly, but we're also, for moral reasons and public health reasons, helping people around the world. Going back as policymaker, I began my discussions with the Bush administration and President Bush in 2000, 2001. I said, Mr. President, we're doing well in the United States of America, but as I go to Africa, I literally am seeing thousands of people die. When I started as a doctor, nobody had died. I watched 500 people die of HIV/AIDS. 2 years later, I watched 10,000 people die. 2 years later, I watched 2 million people die. And 2 years later, I watched 10 million people. And 23 million people have died from a virus that didn't affect us as a nation up until 1981. The State of the Union message, we had dinner, Karen and I had dinner with the President in the Red Room, talked right before the State of the Union about this at length with Secretary General Kofi Annan of the United Nations, and a few nights later, in 2003, he made this announcement of the $15 billion commitment. Later that night, in an interview, after you do this, it's one of these things in politics, after you have a State of the Union speech, it's late at night, 10:30, you want to go home, but all the news people want to talk to you to sort of get their lines for the next day. And in my speech that night, I said, I think I was probably the only person who said it, that the one thing people 5 years from now will say is the single most important thing the President said tonight was his unprecedented commitment to fight HIV/AIDS globally. And I think I'm right about that. I certainly don't remember anything else he said that night. Subsequently, I became chairman of an international task force on HIV, and actually been over in Russia as chair of the CSIS Global Health Threats as well, looking at the issue of HIV. So that's the policy hat. And then I will have this third hat, and that's the international relief hat in terms of my commitment to fighting HIV/AIDS. And I show Bono here. If you're old like me, you know who Bono is because he's my age. But he's reinvented himself about 5 different times, and he's cutting a new DVD now. He, as all of you know, is the leader of U2 and works with Edge, who both of them have been very committed to fighting HIV. And I'm working with them, and they're helping me on my Save the Children Survive to 5 efforts here. But then I'm helping him on an effort called One Vote 08. And I'll come back to that shortly and tell you what it is when I say or suggest some things that you can do. In addition, I work with a group called AfriCare, who tonight in Washington, D.C. has about 3,000 people, the largest African-American HIV/AIDS effort in the world right now in Africa. And I'm on the board. And I mentioned Samaritan's Purse. Samaritan's Purse is a faith-based initiative that Dr. Dick Furman actually started with his brother back in 1970. And through that faith-based initiative, we travel around the world giving care, and have been to about 10 different countries. First medical trip I took was actually in 1998. Have had these annual medical trips. in the last few years have been to Sudan, Kenya, Tanzania, Uganda, Botswana, Namibia, South Africa, Mozambique. Not as majority leader, not as a politician, not as a political figure, but on the ground, taking care of patients, doing surgery. It's given me an insight to be able to go back to Washington, D.C., advise the president and advise others about the travesty that this virus has caused. These are the countries that I've had the pleasure of being in and doing medical mission work. I did it while I was majority leader, did it every year while I was in the United States Senate as well. Began working with Bono in 2002. We've traveled to Uganda together to review HIV and debt relief. And then my last Africa trip was in February, and spent about a week in Kenya operating Rwanda, Sudan, Uganda, and then was over in Bangladesh in August. Are we winning? And the answer is no. With all of this money, with the smartest people, $34 billion in research, we're losing the battle. And that's important, especially those of you who are interested in public health. And as the school here comes alive, that mission of being able to conquer the problems that we've been able to address directly, took a while, but addressed directly, really underscores the importance of why a School of Public Health here in Tennessee exists. The HIV here, the emerging infections here, as well as around the world. What we've come to learn, though, after $18 billion, is that we can't treat our way out of the global AIDS epidemic. About 6 or 7 years ago, we thought we might be able to treat our way out of it. And if there's one statistic I ask you to remember, it's the one in white that I have here. We give therapy, and much of our money now goes to therapy. In fact, Republicans were criticized, and still criticized to a certain extent, for stressing prevention. Abstinence, being faithful, distribution of condoms. We were criticized for that. And on the condom thing, I have to mention that right now the United States has distributed over 1 billion condoms, more than any other country, any other NGO in the world. So when people say you Republicans don't get it, or you think just abstinence, and abstinence is critically important, prevention's important, it is all important, but right now you can't treat your way out of it, because for every new person this year that we put on an antiretroviral therapy, good effective therapy, the prices come down. For every one, there are going to be 7 others newly infected on the same day. There is no way, there's not enough money in the world, if we put our whole GDP on it, that we'd be able to treat everybody. Thus, the answer ultimately is prevention. It's the only way to break the cycle. Let me shift to this second one. Malaria, it's about 1 million, HIV is about 3 million a day or a year who die. Malaria is about 1 million. Some people will say 2 million. It's a lot. Great breakthroughs have occurred. Protect your future. Use these long-lasting insecticide-treated mosquito nets. If you want to save somebody's life tonight when you go home, go on a website like Malaria No More, check the box, and for $10, $5 to get it there and do the education, you'll save a child's life. Not bad. Every 30 seconds a child dies. Malaria is mainly in Africa. It is mainly a children's disease. So when you think malaria, think children and think the developing world. We have committed large increase in overall funding. I think it's important for you to know that, that we are leading again the world in the treatment and research of malaria. Most of it is in Africa. 90% of all the deaths are under the age of 5 that are occurring throughout this band in Africa. The good news, again, it's cheap, it's inexpensive, and it's proven, most of it demonstrated well in the last 4 to 5 years, is fourfold. The mosquito nets, now insecticide treated, not just a barrier. Mosquito flies up, hits the net, and dies. It's not just a barrier keeping them buzzing around because of the insecticide. We have indoor residual spraying, preventive intermittent treatment for pregnant women, and an artemisinin-based combination therapy. Today, if you looked in the newspaper, or some newspapers, New York Times had it, I think Wall Street Journal, you will see a mentioning of a virus or a vaccine possibly on the horizon. It only protects about 45%. It was in Mozambique, only protects about 45%. But if you have 1 million kids dying, and even if it's 45% protection, we have no other vaccine for it, it'll be a tremendous, tremendous breakthrough. The PMI is the President's Malaria Initiative, a $1.2 billion initiative. It's run by USAID. We're challenging other people like in Europe to step up and support it. The goal is to reduce malaria-related mortality by 50% in target countries, and the target is to achieve 85% of coverage for these vulnerable groups with those 4 tools that I mentioned. Funding levels, just again so you'll get a feel overall, the total funding over these last 4 years or 5 years is about $1.2 million for this particular initiative, and so far it's up to 15 countries and will likely go to another 19 countries. The only thing I want to leave you with is that malaria is a huge unsolved problem. Unlike HIV vaccine, we may have a chance at vaccine for HIV. We may never see it. May never see a vaccine. I hope that we do, but we may never. But for malaria, making progress, but we still need both more resources and more focus. Again, I won't go through the overall funding, but it's not just the federal government. You'll see Gates Foundation's put $70 million in, World Bank, huge initiative of $410 million that starts addressing certain gaps in country plans. The Global Fund, which is the same global fund that we use for HIV, also is beginning to increasingly invest in malaria. Let me switch to tuberculosis. It's again, 3 million, 2 million, 1 million people who die every year of tuberculosis. And I will quickly go down to Nairobi, to a hospital in Bomet, Kenya, which is about 240 kilometers or so from Nairobi. You fly in. This is Tenwick Hospital. Is Silas here? I don't know if there he is right here. Well, he's been there many, many times at this particular hospital. This is a faith-based hospital. You fly in, it's beautiful countryside like this. This is the little runway there that if you happen to be able to fly in, you land on it. You have to clear all the cattle off it before, but this is a typical bush airstrip in Africa. You land your airplane and people from all around come out and see that big old iron bird from the sky that flew in. It's still unusual enough for people to really come out, and 10 years ago they came out, and you have to keep a guard there because everybody wants to play on the airplane overnight, and you need some way to get out of there the next day. This is Karen and Dick Furman again. It's a faith-based hospital. We treat, Jesus heals. This is the operating complex that I took a surgical resident down with me 1 year, and his wife came down 3 years later, designed this surgical suite, and now it's a fantastic surgical suite. I may have some pictures of it. Still, you'll have 1 to 2 people in beds at crowded times of year. Still, you don't have all the resources that you would like to have. This is a little boy. This is just from February of this year. Kibet was a 12-year-old. He had paralysis of his lower extremities for about 2 months. He had exposure to TB, but no HIV. Chest X-ray showed a paraspinal mass, and that was it. This was the night that I arrived. Actually, Karen went over to have dinner with some of the medical missionaries, and I went to the hospital to see the patient. And then you can actually palpate this mass on his back, and you can see the paralysis just examining him. And again, didn't know exactly what we would do. Should you treat it or should you operate on it? It's the sort of disease that you don't see in the United States of America. It's a disease of tuberculosis of the spine, of bone. This is the mass itself. This is chest X-ray, right lung, left lung looking at you, but this is the mass. All of this is abnormal. And so we took him to surgery, and I won't show you the surgical slides, because if you just had dinner, you may not want to see the surgical slides. But basically, this is the spine. We debrided the area, and 1 month later, he was walking. He's on TB therapy for a year, and he'll return back to the bush at a prognosis of cure. I use this as an example a little bit because as an American coming in, there are good, actually, physicians who are there, but I'm going to start introducing this concept of medicine as a currency for peace. Because if you can come in and you're contributing, that mom, that family who are there with them begin to trust you, they begin to understand what you're doing, you have a dialogue with them with improved communication. That same night, on February the 18th, Kisma came in, 22-year-old male from a tribe that is in that region. There was a tribal dispute, and he was shot with a bow and arrow in the back of his head. I'm a heart and lung surgeon. I like the chest, and I can do most stuff in the chest. I can fix the esophagus, I can take out lungs, I can take out hearts, I can do bypass and valves. I didn't do that much of what he came in with, because he had this broadhead, this arrow to the skull. So what are you going to do? Well, there aren't a whole lot of other people around there, but this is it. And remember, I'm the expert down here. This is the fellow you just saw, but this is a arrow, then that's all metal. And so what are you going to do? Well, you start to work on it, and this is the AP film, so you can see it came from the back all the way through at his mouth. And after about an hour we worked, I couldn't get this thing out. You can't pull it out because it's a broadhead. It goes in, so you can't pull it out because it's locked into bone in the skull. And so how in the world do you do it? Well, again, we're operating, and I won't go into the surgical slides, but this is the equivalent of a Lefort fracture that we have to actually create. This is his nose up here, and you have to drop down. That's his upper teeth there. You had to drop it down. Forget it. I don't want to show all that. This is not him, but the long and short of it is that we got the arrow out. But it took about 6 to 8 hours to do that. This is just another little boy, Kayla, 11-year-old, attacked by a hyena in his tuchel in the middle of the night. His grandfather killed, his brother was injured. I did not do this surgery, but at this particular hospital, other people from the United States had come down, and there happened to be a plastic surgeon there. I took a picture of this the week that I was there. This was actually done about a week before. Late presentations, again, I'll show this quickly, but there's nothing you can do for this. Again, because of the lack of access to health care, there's a huge need there, and there's really nothing we could do in terms of operating on it. That was squamous cell carcinoma. What are we doing in terms of our tax dollars? USAID is leading the way in terms of contributing to the global reduction of tuberculosis. This is where our USAID, which is our government program, is working today, again, all over the world as we address this whole issue with tuberculosis with real progress. Funding in the program from 1998 to 2006 has been good and supportive. And lastly, let me turn to medicine as a currency for peace and comment a little bit on why I think this is so important. First of all, morally, it's the right thing for us to do. Whether it's $15 billion for HIV/AIDS or $2 billion for malaria, or sending medical missionaries, faith-based and non-faith-based, into these communities, morally it is the right thing to do. If you look at the kids dying of malaria all over the world, they just happen not to be in the United States. They happen to be in Africa, and therefore we go to Africa. Secondly, it makes us safer. And it really boils down to the fact, if you go and you help children around the world in conflict zones, and they happen to be dying, and you save their lives, it is very unlikely that their parents or their family is going to go to war with you. There's a better understanding. There's a human connection to global health, a human connection to medicine and nursing and communication. If you look at makes us safer, what are you talking about? We know that a lack of hope, a lack of health care, a lack of economic development coming from things that happen like in Botswana can lead to a lack of hope. It is that lack of hope that ultimately leads to terrorism. And people say, is terrorism new today? And I think this slide really documents what it is. This is 1968, this is 1988, this is 2003. Don't try to read all of this, but the point is, if you're looking at fatalities and injuries due to terrorist activity, and you can take Iraq off the table, and the curves look the same. Look at it, going up. If you look at the yellow curve, which is incidence of terrorism over time, you see it going up. And again, if you take Iraq and Afghanistan off the table, this is all over the world. This terrorism is real. And where does it come from? It comes from this hopelessness, this anti-West. And if you save a child of a mom, if you can create an economy, if you can provide health to allow that economy to go, it reverses that hopelessness. The 9/11 Commission report, I said it makes us safer. The 9/11 Commission report from 3 years ago said when people lose hope, when societies break down, when countries fragment, the breeding grounds for terrorism are created. And if you look from our intelligence community, the National Military Strategic Plan for the War on Terrorism, 2003, American humanitarian assistance is often key to demonstrating benevolence and goodwill abroad, reinforcing support for local governments, and mitigating problems that extremists exploit to gain support for their cause. So what can we do? How can we make a difference? It's a question I always get. They say, well, Bill, you went to spent 20 years in medicine, so of course you can do this. Or you were in the United States Senate Majority Leader, of course you can do this. Well, that's good, but really and I understand that, but really the power comes in the grassroots. The power comes in what we can do as individuals. And just a couple of examples. I'm running this Survive to 5 campaign I mentioned, a huge 5-year global effort supported by NGOs around the world. There's a website on Save the Children that if you're interested, you can key in, you can register, you can show your support. The Survive to 5 campaign, this is just the way we've got it organized, but what's important is we've got grass tops leadership. I and Bill Bradley, who ran for president, are now the co-chairs of the campaign itself. We depend on grassroots action and obviously corporate sponsorships. One Vote 08, what is it? It's an initiative that Bono and I got together and did. It's bipartisan, Tom Daschle, Bill Frist. Our efforts here are to engage the American people on 5 issues. The 5 issues you see are HIV/AIDS. We've talked about that. We talked about maternal and child health. Tonight we didn't talk about education. Clean water, 1.3 billion people don't have access to clean water. About 2.6 billion people don't have basic sanitation, the #1 killer of children. And we talked a little bit about hunger. To educate the American people so that the next president of the United States will step back and engage on the issues of global poverty, the bottom billion people, as well as global health, HIV/AIDS, malaria, tuberculosis, and clean water. Bono's One campaign, I wear this little white band, and the One campaign looks at debt relief for countries because a lot of these countries have huge debt over time, and how we give debt relief, increase trade to increase their economies, and address the 5 issues that we talked about before. Again, you can register with OneVote or one.org, and it's part of the One Vote 08 campaign. Part of the campaign that Bono does is called the Red Campaign, of buying these red items, that a portion of that money goes to fight HIV/AIDS. Another example, there's a student campaign for child survival, Save the Children. It's a national grassroots student organization. Another example that students here on the ETSU campus can use. Malaria No More, donate $10 tonight to a bed net. Or give them 5 bed nets tonight. It'll save 5 children's lives. That will get to the ground in Africa. I've been on the ground. I know it gets there. It doesn't pass through governments. It actually gets on the ground. How much time we have? We okay? Why don't we show that little video quick, and then I'm going to take some questions. This was again in northern Uganda. The Lord's Resistance Army had just been pushed out of the northern Uganda, which is up north of Kampala. And again, I think this is a reflection of us reaching out and touching people. This is Karen, my wife, and myself. And this woman actually lives with about 10 people in this little hut right there. And again, as we reach out and touch people, I'm absolutely convinced that we make America safer, we make the world safer, and we capture, I think, what Martin Luther King says, this inescapable network of mutuality, which is a single garment, because ultimately the destiny is there, whether it's HIV/AIDS in Africa or whether it's right in this country. And what does affect one directly affects all indirectly. Let's roll that DVD just for a second. It'll give you a little bit of a feel with a little bit of text and a little bit of a texture of what we do on the ground. And then I'll take a few questions about that or anything else. Lives. For the next several moments, I want to take you on another mission, a more personal mission. Right now, I stand in a mission-based hospital here in Louis, Sudan, a long way from the United States of America. Louis, about 1,000 miles south of Khartoum and 500 miles west of the Nile River. Over these next few minutes, I'd like to share with you some of my personal experiences
you might come here for 6 months or 1 month, but that opportunity to give unselfishly is something that otherwise you cannot capture in any way. It's a dream come true. Having seen the humanity, having seen the hope, having seen that humanitarian love and caring that is shared back and forth, it will forever change your life.
Okay, thank you all very much. It's been a real honor to be with you tonight. Thank you. Thank you. Thank you all. Katie, thank you. Chantel, thank you. Thank you all. Thank you. You want me to take, if anybody has a question, I'd be happy to. We're going to be finished in about 3 minutes, but I'd be happy to take any questions if anybody would like to ask questions about anything either that I said. Yes?
Yes, sir. I have just returned from Russia.
Yeah.
Where there is a huge medical crisis.
Yes.
Alcoholism, depression, where they are abandoning their children. And visiting these orphanages will change your life.
Yes.
We need to help the Russian people.
Yes.
This horrendous problems that they're experiencing.
The question, the comment was made in Russia just coming back, and I too spent April in Russia. And I went to Russia actually of interest to start a school of public health. You know, we're blessed in Tennessee now to have a school of public health, but we didn't. 39 states do, but in Russia there is no school of public health. Right now the average man lives there to 53 years of age. Why? Because of hard alcohol. And same thing with women, but really hard alcohol and smoking. And there the challenge is more chronic disease rather than infectious disease. Still HIV AIDS, a lot of it is pushed over to the side. So I agree. I'll be going back in June as well. The analogy, that's why I wanted to mention Bangladesh. What you've heard about Africa in terms of the need and the public health needs apply to Russia. They apply to Bangladesh, India, Appalachia, all over the world. It's really one and the same. Thank you. Another question, comment? Yes?
I'm in the healthcare industry, pharmaceutical wholesaler, sell pharmaceuticals to hospitals from Vanderbilt to Mason or Washington, D.C. One of the things that we see day to day is 340B contracts for hospitals to treat indigent patients. Do you see the government getting more involved in that?
Say that again. You see what?
Contracts, government contracts, hospitals that treat indigent population can buy pharmaceuticals cheap. Do you see the government getting more into helping those hospitals out that treat indigent patients that lose money or don't get?
You know, the question is, what is the government going to do, especially I think with the indigent population in terms of the cost of drugs? The last and probably the most significant bill that I passed in the United States Senate recognized that drugs, unlike 20 years ago, or 30 years ago, medicines are now the most powerful tool in our armamentarium in terms of health treatment itself. And with the cost of drugs today going up as much as they are, will the government step in and in some way subsidize or cross-subsidize? In Africa, HIV/AIDS, when I started down there, a cost of therapy for HIV/AIDS in Africa was about $3,000 a person. These are in economies where $1 a day or $2 a day is sort of the GDP, sort of the growth. It's just too poor to do it. The cost now is only about $300, still expensive, maybe down to $250. That came with a lot of struggles because we had patented drugs, we didn't allow generics. Over time, though, everybody working together, we were able to get that price down from that big down to that big. In this country, I don't see the government coming in and subsidizing for the uninsured directly. It's going to be used more like in Medicaid, for better or for worse, where you say for the Medicaid population, our government program for the poor, you have to give the very best price. And you know better than anybody, that works out okay, but in truth, the flow of money is probably not as transparent as it should be. So I don't think that we're going to see a lot of movement by government today other than at the Medicaid level. One more. One more. Any of the students? Where are the students? Yes.
Okay, I just came from Dr. Tolan, Silas's dad's
From where?
house. Dr. Tolan,
Yeah.
Dr. Daniel Tolan.
Yeah.
And I told him I was coming to see you, and he said to be sure to ask if you're running for president.
If I'm running for president, I just got out of that business. I think, and I'll close on this, because all of you gave me the opportunity to do something that I didn't grow up wanting to do. My goal in life was not to be a United States senator. And in 1992, I'd never thought about being a United States senator. But in 1993, I realized, and make sure I answer your question. These politicians never answer the question. But I realized that health, if you look at health and how long people live, there are 5 determinants of health. And I realized as a doctor, I was doing good transplants and good surgery, and I was doing the sort of healthcare delivery part, which is important. But what you're born with, genetics, has an impact. Your behavior over life has an impact. The environment that you're born into has an impact. And your socioeconomic class has an impact. Obviously, education and all the advantages. And when you walk away from it and look at what health, or say, just use how long you live, is, genetics you can't control very well. As a heart surgeon, I couldn't control that. But what is the one thing that a doctor can do? That of the 5 affects about 20% of keeping people alive. You'd think it'd be a lot more. The environment's about 10%. Genetics is 30%. Behavior is 40%. Socioeconomic status is about 15%. So I was sitting there saying, if, in my opening slide, I really am committed to health, I can wear the doctor's hat and do 20%, or I could do one thing and address all 5, except the genetics, but all 4, and that is to run for the United States Senate. I went as a citizen legislator, very unusual. I doubt you know any politicians who really said and stuck by it, I'm going to serve 2 terms and get out. Politicians may say it, getting in, but they never do it. Never do it. I did it, and people say, gosh, how could you leave majority leader, most powerful position in the legislative branch of the greatest country in the free world? How could you do that? And the answer is pretty easy, because I went into politics. Now you understand it, but before I started talking, you didn't. To use it as a vehicle or a tool to accomplish that goal, to make sure that we could pass Medicare Modernization Act, or address healthcare disparities, or address education, or create jobs, keep taxes low to create jobs. Those are the things that have even more power than me doing a heart transplant, lifting a heart out and putting another one in, as blessed as that is. And that's why I went into politics. And so now I'm at a stage where, what am I going to do for the next 10 or 15 years? I don't really know, except you can see that I'm working in a global arena right now. Health, one-on-one, the individual being a doctor, one on a community being a senator and majority leader, and then now one on a larger community doing global health issues. I'm not going to rule out running for president someday, running for governor someday, if I look back and say that that is an appropriate vehicle to accomplish that goal of giving other people across Tennessee or across America or across the world a healthier, a more prosperous, and a more fulfilling life. As a tool, as an instrument. My goal to be president, I don't have it. My goal to be governor, I don't have it. But if that is a way to accomplish that, and that really kind of ties all this together. The 25th anniversary of the Lamb Lecture, it is an honor for me to be able to share these experiences with you. It really is a call to action that starts with the great news this week in a school of public health, which gives us a vehicle now to address the issues of East Tennessee, to address the issues of the state, of the region, the United States of America, and indeed the world. Thank you all. Great to be with you.